Good afternoon, everyone. My name is Dr. Raquel Romero, and I will be the facilitator for the ECHO session today. I hope you are doing well as your family. Thank you for making the time to join the Long COVID ECHO series. This project is a comprehensive long COVID care for underserved communities. This is an innovative delivery and dissemination model project, also known as a Comunidad. At the UT Health San Antonio, our post-COVID-19 recovery clinic serves San Antonio and a broad, largely rural region in South Texas. We know that this community faces significant health disparity and barriers to care, and misinformation about long COVID remains widespread. To address those challenges, the Comunidad project, this is a 5-year initiative funded by the Agency of Health Care Research and Quality, and the Comunidad Long COVID ECHO seeks to improve and expand long COVID care through innovative, sustainable models in our region and beyond. Now, for those that are new to the ECHO platform, ECHO stands for Extension for Community Health Outcomes, and it serves as a virtual telementoring platform specifically designed to create conversations between communities and subjects of matter experts. At each session, you will see a introduction, and then you want to see didactics and a case presentation and discussion. During that case discussion, members of our community will present a real life cases to address their healthcare needs. Therefore, to ensure privacy, no personal health information is allowed to disclose at any point during the session, but we invite you to be part of this discussion, and I invite you and encourage you to join us by video. If you feel comfortable in doing that, please do so. Now, if you have any issue with the connection, please send a private message to the ECHO IT Kato, who is going to be an assistant in the session today. And kindly, I would like to ask you if you please enter your name and your affiliation and email address. This is for our attendance records. So I would like to go ahead and start with the introductions for our team and presenters. I would like to start with Dr. Sabat. Would you please introduce yourself?
Hi, everyone. I'm Joel Sabat. I'm a general internist, by training, and director of the Reach Center, and we welcome everyone to this long COVID ECHO. This is part of a 5-year grant supported by the Agency for Healthcare Research and Quality. Dr. Lisa Kilpla is one of our PIs, and is Dr. Monica Verduzco Gutierrez. We're very happy to have a guest presenter today, Dr. Mike Brode, and one of our residents from Residence Clinic is going to present the case later on. So welcome.
Thank you, Dr. Sabat. And Dr. Sabat is also our lead specialist who is going to be bringing the summary of the recommendations at the end of the session. Thank you, Sabat. And you mentioned Dr. Kilpella. So would you please introduce yourself?
Hi, everyone. I'm Lisa Smith-Kilpella. I'm one of the principal investigators on the Comunidad grant, an associate professor of medicine. It's great to have you all. Thanks for your time.
Thank you. Dr. Tegranian.
Hi, everybody. My name is Roy Tegranian. I'm a psychologist with the Long COVID Clinic, where I provide psychological services for those suffering from long COVID.
Thank you very much. And we have a presentation in vascular and metabolic sequel. Dr. Brock, would you please introduce yourself?
Yeah, Mike Brode. Good to see everyone again. I am medical director of the post-COVID-19 program here at UT Health Austin, and a general internist.
Thank you very much, and thank you all that joined our session. Please enter your name, and we also encourage you to invite other providers to participate in the sessions. We invite everyone in our community to join us to learn more about the long COVID, and please tell them to join and see what we have been preparing for you all. With no more from my end, I will go ahead and ask Dr. Roy for the didactic presentation. On your time.
Yes. Do you guys see this okay? Awesome.
Yes.
Well,
Yes.
really appreciate it, and excited. This is one of the topics that I've been really interested in, the vascular metabolic effects of long COVID. I have no disclosures. And I always say of like, 6 years into this, we have decided the name is going to be long COVID, but we still do not have any consensus diagnostic criteria, biomarker, or evidence-based treatments. And we'll start with that as always, I'm sure as you all know, but I think before we get into what is long COVID and why I think that term means something very specific, let's not to give anybody trauma, but let's take a step back and look at the acute COVID-19 disease course, because it really has important implications. We know that the virus starts with a more of a flu-like or viral illness phase, and especially with the Omicron variants, this is where for 98 to 99% it stays. Really earlier variants had a tropism for the lungs, and that's when it would start to produce this pulmonary phase at about day 10, leading to the pandemic and all the inpatient hospitalizations. Once again, the Omicron variants really stays in the nasopharynx and does not go to the lungs anymore, so it doesn't produce this phase as much. But I think what is most interesting is we thought most people still think of COVID-19 as a pulmonary virus, but it was really a vascular virus. And people who would have the severe morbidity and mortality associated with hospitalization, it was really because there was diffuse endothelial damage throughout the body, microvascular dysfunction, and microclotting throughout, which led to the severe multi-organ failure. So COVID-19 always has been a primarily vascular disease, explaining a lot of its effects. And our acute treatments were really focused on that antiviral early in the illness and really mitigating the inflammation, driving that vascular inflammation during hospitalization in severe cases. And so what does that mean for post-COVID illness and that extended course if that immune response does not turn off? And I think as we've all experienced, there was like this, there's 50 long-term effects, there's 100, and the most cited still takes the cake. 203 symptoms and 10 organ systems. You've heard this a bunch. And I think sometimes what that people hear is long COVID is everything and therefore it's nothing. But the schema and here's the NASM definition, Dr. Verduzco, it's great, but you can see how they even struggle to put together a summary slide of the illness. But the way I really organize it in my mind from other authors and researchers starting to adopt this is really I say, what are the sequelae of the COVID-19 virus? The first being end organ damage. This is primarily and almost exclusively in a hospitalized cohort, as you'd expect, pulmonary fibrosis, post-ICU syndrome, PTSD, and high rates among that hospitalized cohort. But we can detect that with our traditional tests. The next is a little bit looser, but it's very clear that the COVID-19 infection increases your risk of developing new chronic conditions, type 2 diabetes, MI, we'll talk about that in the metabolic effect, but what many times specialty clinics are called on to take care of new or worsening autoimmune disorders triggered by that inflammation. And the population statistics really show that there is an increased risk, especially in that first year after infection. But I would distinguish those first two, which we can detect with our traditional tests, from what I would really consider long COVID, a third category, which we do not have that biomarker for. Within that, we see a lot of post-viral symptoms, cough, anosmia, sleep disorders, muscle pains. But I think what really trips people up, and we've talked about it in these sessions, is a dysregulated immune response and autonomic dysfunction, people experiencing tachycardia, POTS, GI dysmotility, the dizziness, the imbalance, temperature dysregulation. But for what I'm seeing in clinic, what tends to be the baseline in all these patients is some combination of fatigue, brain fog, and post-exertional malaise. Worsening symptoms after minimal exertion, cognitive, physical, emotional. And as many have pointed out, this has direct overlaps with ME/CFS and probably a lot of shared pathologic features. And so, yes, the Venn diagram can feel overwhelming, but at least today, I always start to think about, these three main categories of how I characterize it, and really what that looks like is more of a post-ICU syndrome, that the virus itself either caused or exacerbated a chronic condition, or long COVID which I describe really as a post-viral chronic fatigue syndrome, plus or minus this neuroinflammatory syndrome, but they really seem interlinked. And once again, as a Venn diagram, people can have be all of the above, which I think is pretty interested in the vascular metabolic effects, because as time goes on, we're really starting to see that that's at the intersection of the long COVID pathophysiology and the new and worsening chronic diseases. And so just to nail that down, it's pretty striking that we do see that heart failure or composite MACE does have an increased risk, hazard ratio 1.55. That is mostly during the first year from infection, although long-term we'll have to see how the more weaker circulating variants affect that. But a big one is what we're seeing is there is large coronary plaque progression. And some authors and editorialists have really said COVID may compress years of cardiometabolic risk into months. And for that metabolic risk, definitely in meta-analyses, we have seen a hazard ratio about 1.46, higher rates of developing type 2 diabetes, and that is thought secondary to direct pancreatic B cell damage or the chronic inflammatory response, but it's probably all mixed. And so I'll go into that because I think the pathophysiology is important. And here's another, it can be dizzying, but for interest of time, we're really seeing that it is primarily a nexus of chronic inflammation, immune dysregulation, and endothelial dysfunction. And it seems to be a chronic inflammatory self-perpetuating cycle. The components of that chronic inflammation, we are seeing many studies showing sustained elevation of the macrophage triad, IL-B1, IL-6, that is very important for atherosclerotic disease and cardiovascular risk, along with interferon signaling in the JAK kinase pathway, and especially complement activation, which affects the endothelium directly. For probably a smaller but significant cohort, we see more direct signs of autoimmunity with B cell response to specific tissues and autoantibodies. But really, going back to the vascular effects, this seems to converge on direct inflammation to endothelial tissue, the accelerated atherosclerosis and hardening of the blood vessels, potentially microclots. That isn't fully established, but is one of the unifying mechanisms that is being explored. And that leads to effects throughout the whole body, especially permeability to the blood-brain barrier, which we think is associated with a lot of the cognitive effects. The open question is, what is driving this? Viral persistent, latent virus? Is this all infection-induced autoimmunity? Probably a lecture for another day. But what we are really seeing is that this neurovascular disorder really converges on damaging the mitochondria, the small fiber nerves, and the microglia in the brain, which starts to link this to all the different 203 symptoms that the studies have identified. And it goes all the way up from the periphery and the cellular level to the vagus nerve, to the brainstem and the cortical regions. The brain and the nervous system is a complex neurovascular bundle, which seems to be the primary target of this pathophysiology. And so there probably is a direct link, and whether there are different phenotypes or exactly how this cascade happens, I still think is an important research question. But a lot of these findings are starting to converge in long COVID and related illnesses, even like ME/CFS. And so, I won't go into this in detail, but I'll say, if you are working someone up with long COVID, I would put them in a higher risk metabolic category, doing your typical primary care workup, looking for alternative etiologies. Maybe that's risk factor driven, especially if they're in the first year from an infection, and especially really thinking about their cardiac risk with a calcium score, EKG. I would be careful with stress testing to not induce post-exertional malaise. And so I'd strongly recommend all providers do pharmacologic stress testing. Once again, screening for POTS, which is a vascular pooling disorder, And we asked all our patients to screen themselves at home and got some links on how to do that. We have identified a lot of people who actually have it when we started routinely screening it and actually just giving them the handout. And high rates of small fiber neuropathy, like diabetes and other causes, the small fiber nerves are exquisitely sensitive to changes in blood flow and the vascular inflammation. And so I think that is why we are seeing high rates. Right now, just kind of close this up in the last couple minutes. I know going very fast, but if we do identify those end organ damage or new chronic diseases, we are still treating that with our best evidence-based interventions. There's no evidence right now that even if it is caused by COVID-19 virus or associated with long COVID, that it should be treated any differently. So, statins, weight loss, we'll talk about the GLP-1s, SGLT2s are being studied, but it would not be treated any differently if we identify them with our traditional tests. For long COVID, as others have talked about, it's really energy management, trying to do some rehab about coping with the illness, symptomatic management with medications, making sure comorbidities like their cardiovascular metabolic risk are well treated. But I think for the targeted therapies, to round this out, of course, a lot of interest in what is the most upstream driver. So viral persistence and using those targets, treating the chronic inflammatory response through different mechanisms, but also the trial evidence also potentially treating the circulatory dysfunction specifically. And the one I'll call out is actually the GLP-1, tirzepatide, semaglutide, the very common seem to be the miracle drugs for everything. But I think there is a lot of excitement for this because they potentially treat the pleiotropic effects across the pathologic axes that we've talked about. It provides vascular protection, decreasing atherosclerosis. That's part of its reduction in MACE events. It has an anti-inflammatory effect. It can reduce CRP, and that's even independent of weight loss. And it's more theoretical, but potential mechanistic evidence that it can help with autonomic function, blood-brain barrier stabilization, and there's some indirect evidence in autoimmune disorders and Parkinson's that people have functional improvement while on these medications. And so there are two active trials. One active trial. It was very exciting. The LOCIT trial, I think, opened enrollment in November, and within 2 weeks, they had 1,000 people sign up. And so that is ongoing. It's a yearly protocol, and we will have good data. They are using the primary outcome as fatigue severity scale. So it's really seeing, does it help the most common symptom of long COVID independent of weight loss? I think they're learning some interesting lessons about tolerability, but the large RECOVER TLC trial is currently in protocol development. They say enrollment in this summer. I'll believe it when I see it. But I do think hopefully they learn the lessons of LOCIT already. And we're going to have some really good data on this potential GLP-1 class of medications. So thank you all. I know that was a lot, but please let me know if you have any questions.
Thank you very much. It's very, very, very interesting. It's a lot of points to learn. 203 symptoms and 10 organs that has been affected by that. Is there any question from our learning community, from our audience?
Dr. Broda, I've got a quick question. So one of the things you mentioned was be careful with exercise versus stress testing. And we know from a mood perspective that exercise is one thing that can improve somebody's mood. How would you recommend, as a treating clinician, that I address the potential risk of them overexerting themselves with the need for them to get out and get some exercise? Is there a test I should be asking them? Have they conducted to get clearance from their treating physician that it's okay for them to exercise?
Yeah, It's a really important, great question. This is a hugely controversial question in the field. I think the question is like, do they have post-exertional malaise? I think the post-exertional malaise is usually not subtle. They do a activity that cognitive, physical, emotional, orthostatic, and they feel terrible afterwards. Usually it's not subtle. And I would argue if they don't have post-exertional malaise, that leads me to question the long COVID diagnosis. It's so central to the illness process. So I start with that, like, you probably got it. And I really counsel in depth of like, that wall is real. If you push through, you will make yourself worse and set back your recovery. And I really take that as like the starting point. If they have enough reserve or that they feel like they are in a physical spot where they can focus on one of those domains, like incorporating more physical activity, I tell them it's a double-edged sword, that if you do nothing, you will have this, you will get more out of shape, you will lose more vascular tone, you will lose more aerobic capacity. But if you do too much, you will exacerbate your underlying illness process. And so I really walk them through, what is the balance, and it's highly personalized and individualized because that wall moves day to day. I do think a physical therapist who is knowledgeable in long COVID can really guide through an individualized plan of finding that perfect balance of just enough to increase aerobic capacity, but not too much. Those are hard to come by. But what I tell patients to arm themselves, if they're going to a physical therapist, that's the only one insurance can cover, as I say. The first question you ask the physical therapist is, how do you monitor and account for post-exertional malaise? And if they get a blank look, like, what? That is a warning sign, get out of there. And if they get a good answer, this is what I do, it's like, okay, you're in good hands. And so I try to arm them with that knowledge. But it really is, it's a balance. And the people who are most severely affected, I don't think like radical wrestling in bed is going to help them. But if they cannot do it, it just makes them worse. Their wall is so bad. We got to focus on other things before recommending any sort of physical exercise. A long answer.
No.
Thank you
Thank
for
you.
that excellent question.
Thank you.
Thank you very much for your question, and so important that individualized care, right? Because with all those symptoms, very, very, very important. There is a comment in the chat, Marisa. You want to elaborate a little bit more in your comment and what you recommend?
Thank you so much. That was an incredibly compact and lovely tour of the terrain of long COVID. I thought it was like so comprehensive. So kudos to the presentation. That was awesome. But I've also seen strange dystonic reactions in this patient population, and even the Lexiscan pharmacologic agents for the stress testing that's not exercise causing that dystonic reaction, which is I haven't even seen in the literature as a possible side effect. So I wondered, do we have a higher threshold for going ahead in stress testing, given that it could have those risks? Thank you.
Yeah, great point. And I think it's always a level of caution is warranted. I typically see people after they've seen 6 doctors and have all the tests. And it's almost always normal. That's why they come and see me. I have a lot of concern about kind of just sending these folks for more testing without really pausing and be like, what is my pretest probability? Like, what do I think they actually have it? Having long COVID does put them at a higher cardiometabolic risk, but we know it's associated with chest pain. That's usually associated with dysautonomia. That can be more of a musculoskeletal or the diffuse pain syndrome. And so it is worth the little extra history to really sound like, does this sound like chest pain that is cardiac chest pain? Because certainly the burden of testing on this population is probably low yield to start with. but could make them worse. And so I do not take that lightly. So I agree.
Thank you. Yeah, awesome.
Thank you very much, Marisa. Thank you, Dr. Broad. She also says, I recommend going to Tai Chi. Well, that's what's in the chat. So we promise to read all the messages in the chat. Well, if that's okay too, we are going to now move to the case presentation. Dr. Ali, you have a case to present, but thank you so much, Dr. Broad. This is a wonderful, wonderful didactic presentation.
Hey, can you guys hear me?
Yes, very good. Thank you.
Okay, perfect. Hi, I'm Rashani Ali. I'm a third-year resident at UT Health San Antonio, and I'm just going to briefly talk about a case that I saw in my continuity clinic. This is a patient who's a 52-year-old female with past medical history of poorly controlled type 2 diabetes on insulin, obesity, hyperlipidemia, and hypertension, who presented in October of 2020, so pretty early on in the COVID era, with shortness of breath, pleuritic chest pain, cough, nausea, vomiting, and dizziness. She had actually been diagnosed with flu pneumonia about a couple days prior and was on Tamiflu as well as a steroid taper for bronchitis. But upon arrival to the emergency department, she ended up testing positive for COVID pneumonia. And so she was formally diagnosed with an asthma exacerbation with like dual virus, so flu pneumonia as well as COVID pneumonia. Couple things about her is that during her ED visit, she was saturating well on room air. She never required oxygen supplementation. Her chest x-ray was pretty much clear, didn't show any radiographic abnormality, and her white blood cell count remained at 5.3. So no greatly concerning findings, but her, I guess, post-hospital discharge course had been complicated by a number of manifestations that were later on determined to be long COVID. So she had multiple hospitalizations for recurrent chest pain. She followed with a cardiologist, underwent stress testing that was all negative. She even underwent catheterization that showed non-obstructive CAD. She, in addition to that, was chronically tachycardic with heart rates up above the 100s. And so she was determined to have POTS disease that was confirmed on tilt table testing. She had more hospitalizations for, I guess, subjective dyspnea, for which her PFTs ended up showing a mild restrictive disease that had kind of progressively developed at least 2 years after the initial COVID diagnosis. She had a mild diffusion defect with that as well, but again, never required supplemental oxygen. And then I would say the most severe clinical manifestation that she developed, again, progressively over time, was dysautonomia, where she ended up having bilateral upper extremity and lower extremity weakness and fatigue. She underwent EMGs of the bilateral upper and lower extremities, and the upper extremities pretty much showed some kind of neuropathy confirmed on EMG, but the lower extremities were fine. However, her fatigue was so severe that she ended up being wheelchair bound. She, developed brain fog, dizziness, vertigo, such that she just didn't feel stable walking on her own, and experienced recurrent falls. So overall, she was just kind of, at the current state today, she's still wheelchair bound. And this is from somebody who was completely functional, able to do all ADLs prior to her COVID illness. And I would say the last kind of abnormal manifestation for her was chronic joint pain. She ended up having an atypical ANA. Her ANA level was greater than 1200. She had underwent subsequent rheumatologic evaluation and workup, but nothing was really determined to be, I guess, positive. So she was just determined to have more of a fibromyalgia or a long COVID disease rather than a rheumatologic condition. So during her, I guess, clinical course, she's kind of had to see, as I mentioned, rheumatology, neurology, cardiology, orthopedic surgery for carpal tunnel, bilateral carpal tunnel release. She's kind of gone to urgent care multiple times. She also has, gone to the ED for this kind of symptomatic chest pain that has always been deemed negative with negative troponins and EKG. And overall, she's just very deconditioned, being wheelchair bound. So that's a little bit, I guess, like about this case. We're now in 2026, long after her initial COVID diagnosis. And where we are today is that she's kind of determined to be a patient with long COVID, and she's had referrals to um, the long COVID clinic. And so she's pending evaluation there at this time. Different providers have kind of said different things to her. Frequently, she's been told by multiple providers that she has like a functional neurologic syndrome or a conversion disorder. But at the same time, we see that she has actually been diagnosed with new lung findings of mild restrictive lung disease. She's been diagnosed with elevated inflammatory markers, including her ANA, as well as overall deconditioning, now being wheelchair bound, and POTS disease confirmed on tilt table testing. So I guess one of the questions I just wanted to ask for the group as part of the inquiry form was just kind of how do you distinguish manifestations of long COVID versus like a functional neurologic disorder if a subspecialist suggests that?
Thank you so much, Dr. Ali, to walk us through that case. For the first question, is there any comment from our hub and our audience?
Before we answer that, or try to answer that, if there is an answer for that. Yeah, so I was attending in the clinic on Monday, and Dr. Ali presented this case to me, and it was like a 52-year-old woman who's being followed in our clinic, residence clinic. And that particular day, she requested a jury duty excuse. And I'm like, okay, I'd never seen her before. And I'm like, she's 52 years old. She's trying to get out of jury duty. What's up? But then the more I heard about her, and then when I saw her, I was just struck by how debilitated she was. I mean, she was 6 years ago, I guess, perfectly functional, working, had a daughter, had a family, everything was normal in that way. And now she is, almost confined to a wheelchair and just can't do anything. And she's got brain fog, has all these other things. So it's one of the most debilitating cases I've seen of long COVID.
Thank you, Dr. Sarfo. Give us a little bit more context of the situation and the circumstances of the patient, and very, very important to have a whole understanding. And so for the first question, how can we distinguish functional neurological syndrome, conversion disorder from manifestations of long COVID? What do we all think about it?
She did have abnormal EMGs and CVs, right?
Dr. Ali?
Yes, her initial EMG of the bilateral upper extremity was abnormal after her long COVID, but the lower extremities were not abnormal. They were just fine. She still developed kind of weakness, dizziness, instability, being wheelchair bound.
And she has been followed by neurology, right? So hopefully they weren't the ones who said functional neurologic disability, but
they were the ones.
Oh, they were, no.
Who said that. And so, I mean, they were the ones who just couldn't really distinguish long COVID versus functional neurologic syndrome. So I think that was something that was.
Any thoughts from?
Oh,
Dr.
sorry.
Zajac? Yeah.
Yes. So I hate to also share an unfortunate story of functional neurologic states, but going back to this dystonic reaction and the effects of the dopamine pathways of long COVID itself, I had a patient that I sent for admission, a pediatric patient, 16 years old, who was starting to have episodes while driving, and like she would just feel like suddenly tired and kind of like have a syncopal event versus a seizure-like event. And it turns out that she was diagnosed by EEG with functional seizures, pseudo seizures that were sent to psychiatry, and she was having oculogyric crises. So, a very pronounced like retrocollis of the head, like her head would flex backward and her eyes would flutter, and she could talk and she could, follow commands. But the thing that psychiatry did really well was put her on Cogentin for this like dystonic reaction that she was having with all sorts of psychiatric drugs as well. And I think it was promethazine that ended up causing this oculogyric crises because she had such profound gut issues from this. So I think it's very difficult. It is very difficult because these neurologic workups, when you look at only the test on paper and not the patient in front of you, it's hard to recognize that it's something else going on. And it honestly took me a long time to recognize the look of an oculogyric crisis over a seizure or a syncopal event. So, I even recognized it 3 months after it started. And she had been through all the workup, and then I saw her again, and I was like, oh, this is it. And she had been through a lot of other doctor's visits, hospitalizations, and other stuff. So yeah, it's really difficult. You have to look at the patient in front of you and not at just my chart or the paper and those tests, what they show. Thank you. That was a great presentation.
Thank you, Dr. Eliak. Thank you so much for this comment. Maybe are we ready to move to the second question? Are new symptoms a product of long COVID alone, or does one new symptom result in manifestation of other symptoms? For example, does long COVID result in both POTS and dysautonomia? Let me see if I can pronounce it better.
Yeah, just kind of the thought, like in this case, we're kind of seeing multiple manifestations of long COVID that were highlighted in the initial presentation. But I guess just kind of moving forward, recognizing perhaps pattern recognition, like to some degree, is her inability to function to a certain degree, kind of lethargy, weakness, diffusely, resulting in her POTS disease, or vice versa? Or are these just multiple manifestations of long COVID? It's kind of more of a food for thought question, I guess.
Okay, thank you for asking and clarifying that question. Dr. Sabat or Dr. Broad, any comment on that?
I don't have an answer for that, only to say that long COVID symptoms are very nonspecific, and they can be seen in pretty much many other things. And so that may be one of the reasons she got bounced around from doctor to doctor and got test after test after test. And part of the problem was a lot of, as you know, clinicians either are unaware of long COVID and how it presents, or don't think it's a serious problem. I don't know, Dr. Bro, do you have any thoughts about that?
Yeah, I would say, first of all, the term functional neurologic disorder has a lot of baggage. And if anybody's online forums or looking at long COVID communities, they're talking about it a lot. Patients hate it. It is not a patient-centered term, even though I think doctors, it has its own baggage when doctors think about it, although it does have a very technical, non-judgmental definition, but I always try to stay away from it just because of the baggage. I think, the distinguishing is always back to the history. In my experience, it really is like, people will start to experience a change in their health within 6 to 8 weeks after a COVID infection. And it's usually pretty sudden. If this happens subacutely or 6 months, a year after full recovery, I really pump the brakes and say, like, let's make sure we've eliminated all other causes. But you're right. I think what we see a lot is the neurologic dysfunction is happening at multiple levels, both peripheral sensation, from small fiber neuropathy to the integration of the autonomic nervous center systems in the brainstem, the cortical integration of how they experience that subjectively. And so I do think fundamentally people's sensation of their own body, interoception, is not working correctly. And so we see almost like the disease process affects, changes the calibration of how the body understands itself. And that is one of the big leading disconnects of why they may feel symptoms and what we can measure. And I also think a little bit of humility of like, well, we can't measure everything. So I still think it's the stepwise is, does the history fit? Is it a cluster of interrelated symptoms? Is there post-exertional malaise on that time course from infection? Have we ruled out alternative causes? Or are there like weird things like, I always give the example of somebody had classic long COVID symptoms in my clinic a couple weeks ago, and they're like, oh, and everybody just says the thrombocytopenia I have is from long COVID. I thought, I've never seen thrombocytopenia with long COVID. And it turns out she was experiencing allopurinol toxicity with fatigue and all these neurologic symptoms and thrombocytopenia. And she just started taking it after a long COVID episode. So I do think it is just also having a serial evaluation with the same patient. It will probably take multiple visits to tease all that out.
Yeah, I will imagine that it will take several appointments, several encounters just to first articulate the symptoms and recognizing the symptoms, and then how we can explain as a patient those symptoms. Dr. Marisa Sajak, I hope I pronounced their last name correctly. You have a comment that you would like to also elaborate a little more in?
Thank you, Mr. Romero. I guess I'm in agreement with this amplified interoception. There's some sort of maybe neurodivergence that was pre-existing or changes in the brain that now cause this. But there's an exaggerated distress from the like tachycardia. There's an exaggerated distress from feeling digestive peristalsis, and it causes like bad nausea and like bad symptoms that are out of proportion for the like physiologic states, I believe, from the patient's perspective. And also, I think that, coming from like the DO perspective and working hands-on, doing manipulation, it seems that like the small fiber myofascial pain syndromes become, extremely amplified in terms of like the sensitivity of the fascia, and it's like has 100 to 200 million free nerve endings in it, and is now almost classified as the most sensitive organ of special senses. So there's like a huge feedback loop of amplified pain and sensitization with this. So thank you.
Thank you very much, and thank you for having this kind heart and trying to understand every single outcome from patients, because it is difficult for all of us to sometimes articulate some symptoms, particularly if it is new, if it's overwhelming, and also tiredness. And Dr. Pepela, you also mentioned something in the chat that I think is very pertinent.
Thank you, Dr. Romero. I was just commenting that there's a similar sort of process that you see in panic disorder where there's a hypersensitivity, hyperawareness, hyperfocus on any sort of interoceptive sensations and sort of sensitivity and overinterpretation of any sort of internal stimuli, typically normal and not even abnormal internal stimuli. So you kind of see a similar a parallel process, I will say. I'm not saying that it is panic disorder, but it's a parallel process that you can see with the more you focus on something, the bigger it becomes. So
Yeah, thank you so much. Very, very, very important. I learn a little bit more in this overwhelming situation. The last question is, can we use the same diagnostic studies to confirm or deny manifestations of long COVID? Dr.
Yeah,
Ali?
like I guess just this question kind of goes back to the fact that I guess how do we categorize what's really going on and do our diagnostic studies translate from one known illness to long COVID? Yes, we did use tilt table studies to confirm POTS disease. EMG studies, however, were kind of ambiguous, showing more upper extremity deficits, whereas the patient had more lower extremity weakness. So just kind of what are kind of when you suspect long COVID in a patient who may be told that they have functional neurologic syndrome, what kind of diagnostic studies can we consider to help verify what might be going on, or at least diagnostic criteria could be used to diagnose long COVID?
Thank you very much. I will ask Dr. Brock, do you have any comment in this regard?
Can you repeat that? I was typing something in the chat and all of this.
Oh, you can articulate that. You can elaborate in the chat.
Well, yeah, it was just about diagnostic studies used to what diagnostic studies are we using for long COVID? And do they really, how can we be more creative maybe with kind of coming to this diagnosis, particularly in this patient who was kind of deemed to have possible functional neurologic syndrome?
I'd say there's no single test, and those are still if rule out tests to identify alternative causes. And if the history is atypical or presentation severe, we'll do more and more testing, probably looking more autoimmune or genetic predispositions. We have found a high rate of small fiber neuropathy, and so I've started incorporating punch biopsies into my practice, and I don't know how available those are, but about 60% of our patients with the neuropathic symptoms will have that. And that usually coincides with more of the severe presentations, including both the neuropathic pain, fatigue, and autonomic dysfunction. Those seem to go hand in hand. But it also means 40% of our patients with those same exact symptoms have normal studies. So once again, it probably is happening at multiple levels. I do think there's some whispers of potential biomarkers from long COVID going to be proposed out of all the research happening in the last 6 years, but I think that's really to be determined when those studies come out. But there's nothing, if anybody says they have the test for long COVID, they are either lying or extremely lucky that they found the one when the rest of us didn't.
Thank you very much for your comment. We are at the end of the hour. We just have 1 minute, but I would like to respect everyone's time and your kindness to come with us and express your opinions. This is an opportunity to learn. This is ECHO is all teach on learn environment. So I will ask Dr. Sabat, who is now the lead specialist, to give us a summary of the recommendations. And we hope, Dr. Ali, all your questions were answered today.
Yes, thank you first, Dr. Broad and Dr. Ali for those great presentations. We learned again that long COVID is a multi-system disease, chronic disease, with no single diagnostic test and no magic bullet treatment yet. But that doesn't mean there's nothing we can do for these patients, because there certainly is. I do want to mention that I think Dr. Broad mentioned some clinical trials that are ongoing. San Antonio is one of the sites for the RECOVER study. So you did mention one of the RECOVER studies. we are planning to do an echo on Recover results from their cohort studies and clinical trials, and also information about upcoming studies for your patients. And then one last thing, we encourage our community members to submit cases to us. Happy to discuss anything related to long COVID or the healthcare system involved in long COVID, or anything that you're seeing. So please submit those. And with that, again, thanks everyone for attending.
Thank you, everyone, and please join us next month and bring your questions and invite other colleagues to be part of this ECHO community and learn together. ECHO, like I said, is all teach and learn environment, so we invite everyone to be part of this learning community. There is few links in the chat, and one is if you're interested in presenting a case, we encourage you, I invite you to present a case, like Dr. Sabat mentioned, in our future sessions, and also maybe a follow-up from a case that has been already presented. So we'd like to see how this been managed to you, and we can learn from that. I would like to say a huge thanks, capital letters and bold, for you all be here. Dr. Broad, wonderful didactics, all the case for today. Dr. Ali, all the comments from everyone. Thank you so much, and I will see you next month. You have a wonderful end of the day.